Well, good morning, and I would like to welcome everyone to today's Health Scrutiny Committee. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also like to welcome Councillor Colin Matthews, the Executive Support Councillor for NHS Liaison, Community Engagement, Registration and Coroner's Services, and our substitute members, Councillor Devereux and Councillor Boston. Other participants will be introduced when we reach their item, and I would like to ask for all mobiles to be switched off or placed on silent, please. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillor Mrs Lucille Haighes, Mrs Sandra Harrison and Dr Mike Thompson. And as you said earlier, Chairman, we've got replacement members. We've got Councillor Terry Boston from North Kesteven District Council and Sarah Devereux from East Lindsey District Council. We've also had an apology from Councillor Sue Woolley, Executive Councillor for NHS Liaison, Community Engagement, Registration and Coroners. Thank you, Chairman.
Thank you, Trina. We'll like to move on to agenda item 2, in which case, declarations of members' interest. Do members have any interest they wish to declare at this point? No? Okay, thank you. If one does come up throughout the meeting, then please just raise and we will note it at that point. I'll now move into agenda item 3, the minutes from the 21st of July 2021. Can I have a proposal that we confirm those minutes from pages 3 to 15 on the agenda? As the committee have had the opportunity to read these in advance of the meeting, I do plan on taking these en bloc. Thank you, Councillor Cabry-Brown. Seconded, Councillor Wootton. Thank you. All those in favour, please show. Thank you. Those against and abstentions. Thank you, Councillor Boston. Thank you. They're moved. We'll now move on to agenda item 4, Chairman's announcements. My Chairman's announcements have been circulated with the agenda and my supplementary announcements were emailed on the 14th of September. Are there any questions in regard to these, please? Councillor Wootton.
Yes, thank you, Chairman. In relation to item 3, the future, the NHS plan, health plan regarding new hospitals, can you tell me whether ULHT have or CCG have put in any interest on a new build or improvements to the hospitals in the area, particularly Grantham? Thank you.
Thank you, Councillor Wootton. I don't think we have the full details as of yet at the moment in time. I think they're looking at a number of improvements to hospitals and possible new hospital sites of the smaller community style. But until we've got those details, I can only speculate for the time being. But of course, as soon as we know, we'll feed it out to members of the committee. Thank you. Any other questions? Dr Wookey, sorry.
Thank you, Chairman. Just a clarification on page 18, which is urology, and the Health Scrutiny Committee came to a decision in June and July regarding this. Health Watch, at my request, considered this a week or two ago to try and rationalise our opinion, and it was really to say, you know, what is the next step? Because Health Scrutiny had reservations and felt it couldn't support the proposal at that time. We felt that in principle, we supported it because the urology service currently is not up to adequate quality. But there were reservations, particularly around the southeast and around Boston. So I just wondered what the next steps that the committee was going to take, because it would be good if we keep liaison about this, because I think at the moment ULHT are going ahead, but it isn't clear exactly how this is going to be followed up.
Simon, would you like to come in?
Thank you, Chairman. Yes, we need to bear this in mind and keep it on the work programme, and maybe the committee might be minded to ask for an update perhaps in 6 months from the implementation of the new arrangements, maybe early in 2022. Thank you, Chairman.
Thank you, Dr Wookey, and we'll make sure that that's added to the work programme later. Councillor Woodliff.
Thank you, Chairman. Yes, well, there's a very great concern in Boston about the impact upon Pilgrim Hospital. There's a general feeling that everything's been moved away from there. Now, that's not true, but the perception in the town is that the hospital itself is under threat, because there's always this feeling that everything is being shifted away to County Hospital in Lincoln, as you're probably aware. I mean, up in Skegness, it's probably maybe the same feeling. I don't know, but it is a worry, and I think that the ULH has got to go a long way to reassure people in the area that the service will improve from this, and not leave people in Boston with a third-rate service, whereas people in Lincoln have a first-rate service because they'll have everything on their doorstep. That's really the concern. So I agree. It needs to be retained on the work programme, and we need to keep a very close eye on this. I did raise this issue 2 years ago. You may have remembered in the meeting that a consultant did raise this whole issue about the movement of urology, and I was told at the time that there was, by the people concerned, there was no possibility of it essentially. But we know now the truth. Anyway, I'll leave it at that. Thank you, Chairman.
Thank you, Councillor Woodliff. I think we've, throughout the time of the engagement for the healthy conversation, as well as the ASR as it's moved forward and all the other changes that they're looking at, we have always had those concerns of centralising everything to one location, and it is something the committee has always fought against, and I'm sure will continue to do so without, good qualification of why they're doing so. So it is something we'll keep a close watching eye on. Thank you, Councillor Woodliff.
Thank you, Chairman, very much for your support. Thank you.
Thank you. In which case, I think we've all had a good discussion around these. Do I have a proposer that these are noted with the announcements that have been tabled and emailed today? Thank you, Councillor Wootton. Do I have a seconder? Thank you. That's been seconded. All those in favour, please show. Thank you. That's supported. I'd now like to, before we move into the substantive part of the meeting, would like to ask for your questions and contributions to remain concise and succinct, and ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'd now like to move into agenda item 5, the Lakeside Healthcare Practice Stamford, which you will find on pages 47 to 52 of the agenda pack. I'd also like to welcome our presenters from the Lincolnshire Clinical Commissioning Group, Wendy Martin, Associate Director of Nursing and Quality, Andy Ricks, Chief Operating Officer, South Locality, and Nick Blake, Head of Transformation and Delivery for the South Locality. If I can hand over to you for about 10 to 15 minutes just to run us through, and then we'll take questions at the end, please. Thank you.
Sorry, dreaded mute button. Wendy Martin, Associate Director of Nursing with the CCG. I can't actually see my colleague Nick as yet, who's going to join us, but I'll start off. Can I just give, first of all, apologies for Andy Ricks, because he had a significant health event about a week ago, and he's likely to be off sick for a while, so he's not able to attend today, so just for information. If I start, obviously you've received our report. And that just gives a bit of background to Lakeside, and you've been able to read that in terms of the fact that Lakeside in Stamford operates from 2 sites, both Sheep Market Surgery and St Mary's Medical Centre, and it has on-site dispensaries at both sites. It serves a population of registered patients of just under 31,000 patients, and it's provided through to GP practice, obviously at those 2 sites, but Lakeside works within a partnership of GP practices called the Lakeside Healthcare Partnership, which has practices across Northamptonshire, Lincolnshire and Cambridgeshire. And the central function, support function, is located at the Corby site in Northamptonshire. It just gives a bit of information around deprivation levels, but it's not a particularly deprived area of the county. But obviously it's got its needs like any other area of the county. It just highlights that during the pandemic, like other GP practices, face-to-face consultations were restricted, and there was that move to mainly telephone triage in the first instance, but seeing patients where it was necessary face-to-face. Stamford had a CQC inspection on the 8th of June. That followed significant concerns raised around through complaint processes about patient access, and we'd already been working with Stamford practice to improve their telephone access, and at that point they'd just almost at the same time implemented a new telephony system. The CQC report has been shared, and the paper just provides a summary of the feedback from the CQC. Obviously, significant concerns noted, and the practice was put into special measures and given an overall inadequate rating, and an inadequate rating in many areas of the CQC, the majority of areas of the CQC inspection, and significant concerns were noted in terms of a backlog of medication and patient reviews, also issues in terms of access, as I've alluded to, and the number of complaints around access, the staff support, training and overall leadership of the practice, and also some issues around the dispensary. Since we've been involved, obviously the practice informed us on receipt of the CQC feedback about the issues with the CQC, so the CCG have been involved since that time in terms of making sure that this practice had an appropriate action plan in place to address all the concerns that have been raised, and that there were a full trajectory of improvement at a good pace of improvement in terms of in terms of the actions that were required. Shall I stop there? I just wondered if my colleague Nick had arrived, just if you wanted to add anything to what I just said.
Thanks, Wendy. Yes, I managed to join. Apologies for being slightly late. I was caught in another meeting. I don't think anything to add from Wendy from what I have heard. As you say, we've been working with Lakeside on their action plan to mitigate the issues.
Sorry, it's incredibly muffled. We can't hear you at all well in the chamber.
I beg your pardon. Is that better?
No, it's still very, very muffled.
I might try logging out and logging back in again. Let me try. Is that any clearer?
No, it's not really. We really can't hear you, I'm afraid.
Okay, apologies. I'll try leaving and rejoining, but just to say, nothing particularly I needed to add. I think Wendy had summarised the points very clearly. Thank you. Apologies. I'll rejoin in a second.
Okay, thank you.
Can I just say there is a full action plan, which is quite a lengthy action plan, which is shared with both the CQC and CCG. We have asked the practice for a summarised version of that. It's not yet available to us, but I will share that so the committee has access to that as soon as possible. They have also been improving their communications publicly and have launched through local media information about the actions that they are taking. Maybe if I just go through some of the actions and give a bit of an update in terms of the summary of actions, if that would be useful.
Yes, please, that would be very helpful, thank you.
So the first one that I've alluded to there in terms of telephone access and waiting times, as I said, a new telephone system for access particularly was implemented in June. Waiting times have significantly reduced. There are still some concerns being raised, but nothing like the numbers that were being raised before the new telephone system was put in place. At the time of the CQC visit, that wasn't quite established and up and running, but there have been significant improvements in terms of monitoring of those wait times, and they're now minutes, whereas before they were long minutes rather than just a few minutes. So in the majority, at peak times, it still seems to be a bit of an issue. So there's still work ongoing on that. There has been particularly a focus on staffing. This practice particularly had suffered with staff leaving and partnership changes during the COVID response. They have managed to recruit 3 further salaried GPs, which are starting this month. They've recruited they've now recruited a practice manager and also a customer support officer, which will be particularly pertinent in terms of improving their relationships with patients and the public. They've also recruited additional administrators. There still are issues in terms of nurse staffing and focus on recruitment for nurse staffing, and also in terms of ensuring the staffing for the dispensary is appropriate, and they're still undertaking work to address that, but obviously we're monitoring that to make sure those improvements are made. We've ensured they are taking steps to improve their complaint processes, and also ensuring that it's a lot easier for patients to raise concerns. And indeed, the CCG have attended a couple of the PPG meetings that the practice facilitate with the patient participation group of the practice. And we have talked through that group in terms of improving those communications, and also the PPG are now undertaking a survey just to understand any ongoing concerns that patients and the public have in terms of lakeside care provision. The next bit just talks about the additional capacity improvements in terms of workforce. There were significant issues raised around staff training, appraisal and supervision. And they have done quite a lot of work in terms of ensuring there's an extensive support in place for staff now, and that has been supported by the sort of Corby management team, senior management team. So they've had additional support from senior leaders around management and leadership. All staff appraisals have now been undertaken or scheduled by the end of September, and they're having regular listening clinics with staff, and also having regular team meetings with staff to ensure that they understand any concerns that staff have, so that they can be taken forward and addressed. The medication and long-term condition review backlog, obviously that was our greatest area of concern in terms of patient safety. To report to the committee that at this point in time, they've done the vast majority of those reviews. It's even a better position than reported in this paper. And those reviews, patient reviews and medication reviews, are all set to be completed by the end of October. Most of our general practices, because of the pandemic and the pressures of the pandemic, have accrued some delays in reviews of patients, because an element of the reviews often involves a need to do face-to-face interactions. But for Lakeside particularly, a much improved position in terms of those medication reviews, and also patient with long-term condition reviews. Dispensary processes, there were some quite significant issues in terms of procedures within the dispensary. They've all been addressed in terms of an ability for override for prescribing. That's all been changed and altered and improved. As I say, I think there is still work to do in some areas in terms of staffing and that support for staff. But all these things we are monitoring and ensuring actions are taken through the action plan. The CQC have done a re-inspection visit in terms of the warning notices and enforcement actions that were issued to the practice. The practice have reported back that the CQC have noted the improvements made, particularly around medication and long-term conditions, but still work to do in some areas. So I'll stop there, and then obviously if there's any questions, happy to answer those.
Okay, thank you. Councillor Allen.
Thank you, Chairman. I'm new to the Health Scrutiny Committee, and indeed to lots of these issues that are facing us in the overall NHS system. I've got some queries just to further my own knowledge, that's all right. Can you tell me if the how the CQC got involved with the issues in this particular practice? Was it simply as a result of a regular inspection, or was it as a result of complaints that had been received either directly by the CQC or through the practice that the practice decided to pass on to the CQC? So that's one question. How does the CQC get involved in a practice that is apparently failing? and does the report, and indeed makes the recommendations that the practice ought to then pick up. And I've got a second question, if that's all right, as a follow-up to that. Looking at it from a customer's perspective, I mean, the CQC has made comments. There's been an action plan put forward in response to that by the practice itself. But does anybody, and indeed you can go back into the practice and see if that action plan has been put into effect, and whether all of the aspects of the CQC's concerns have been addressed by actions and action plans. But does anybody go back to the actual customers, the patients themselves, and ask them, are the concerns that you had been addressed, or do you see a substantial difference and benefit or betterment in the way that the practice is providing its services to the patients in the community?
Okay, shall I answer those? So the first one, the CQC concerns. In view of this practice, it had previously got a good rating from the CQC, so it wasn't due to be re-inspected by the CQC, but there were a significant number of concerns being raised around access through to this practice, and that's why the CQC got involved and did a more thorough inspection visit.
Were those concerns coming from patients?
Patients, yes, sorry, patient concerns direct to the CQC, I believe, and also through to Health Watch.
Thank you. And the second question was, you know, how do you determine whether the customer is seeing the benefits of the action plans and the actions that have been put in place as a result of your comments, and indeed, you know, what actions the practice has decided to do?
Yeah, so at the moment, in terms of that, the PPG is leading on a survey which has been put out through the local media in terms of what patients are experiencing now and whether they've got any ongoing concerns. That in terms of advice from the CCG and also other stakeholders is that that's obviously needs to be a continuous listening exercise in terms of whether there are ongoing concerns and whether things raised previously have been addressed. And Health Watch have been helping CQC and indeed the practice in terms of understanding what the concerns are.
Thank you.
Thank you. I've got Councillor Ray Woods next, please.
Yeah, thank you, Chairman. It's nothing to do with the actual subject, but I find it extremely difficult to hear what the speakers are saying. Now, we had this problem yesterday at committee, and we found that the people speaking on Teams were mumbling or weren't speaking clearly to the microphone. I'm sure Councillor Cleaver would agree with me, and Councillor Linda Woodson. Yet those speaking in the chamber we could hear clearly. So can we have more people in the chamber presenting as soon as possible, please? Thank you.
Yeah, thank you, Councillor Wootton. I think from what we understand, when we've spoken to our NHS colleagues, they weren't planning on anyone coming into the chamber or meeting in person much before October, November time. So we have to go with the will of what the NHS wish and, of course, on safety grounds.
Can I just apologise? I will try to speak more clearly.
Thank you very much. Thank you.
Get a bit closer to the microphone.
Okay, thank you. Dr. Wookey.
Thank you, Chairman. Health Watch has just been mentioned, has been involved with the problems in Stamford for some while now, and I think we've discussed this again about a week or two ago, and there are very definitely signs of improvement, and I would concur with what the CCG has said, that the progress is being made and it's being monitored by the CQC. What is depressing is that this was brought to attention by patients and by the previous PPG, which eventually resigned en masse because it felt it wasn't being heard, that action had to be taken. Action didn't seem to have been taken because there was a feedback directly between patients and practice, as there should have been. So I think, although things are improving, I think it's far from certain that things are on an even keel. I won't go into too much detail, but there are a lot of questions as to how this originally arose and what the decision-making process was. And mentioned in your report is concern about communications between Corby, the headquarters of the organisation, and the local practice staff. And it did seem that this process of remote jurisdiction was simply not happening. This is not an occasion just in Lincolnshire, it's happening elsewhere in the country where large groups are taking over groups of dental and medical practices, and it does call into question whether the local voice is being heard and the local providers of the service are actually being heard either. So I think we want to be fairly cautious of welcoming what has happened, but I think there is some way to go, and I think it does need close observation. It's not, as we know, the only practice in Lincolnshire that's suffering some problems at the moment, and it's still quite difficult to know how much of this is the pressures of COVID and other things, and how much of it is the management of the practices themselves. And I know this is on the agenda in a month's time for this committee, but so I think a cautious welcome to what is being happening, but I think there is a more deep-seated problem about the communications in these large groups that are being formed, and I think it's something that I think we should view with some concern.
Thank you, Dr. Wookey. Yes, I would entirely agree with what you've had to say. Okay, I have Councillor Parkin next, please.
Thank you, Chairman. A couple of points. It was a similar point to Dr. Wookey, really. We're talking about, you know, how much of these problems, how much of the difficulties that they've been in have been compounded by COVID. Is it COVID that's actually finally pushed the practice over the edge because they didn't have the capacity and the resilience that other practices may have had, and what lessons do we learn there about moving forward, not just for this practice but for practices across the county, because it would be awful if there were lessons to be learnt here that were relevant elsewhere but we didn't learn from them and put strategies in place to help other practices. But also it's just a really confused by a section of the report. I've sat on the patient participation group in Louth for my own surgery, and I know they're really important. And it talked about, this is on page, well, it's paragraph 5, outline engagement, and it says the PBG has been through a number of major changes over recent months with a completely new committee having been established with a new chair. But then it says, following the resignation of the new chair at the end of July, a new is in place. So has, you know, are the issues that they were in now being compounded because the new chair has resigned, or is this just a typo and a badly worded sentence? I couldn't quite make head and tail of that.
I don't know, Nick, if you wanted to respond to that one, but I can answer it if needs be.
I'll try to, and hopefully the chamber can hear me, but please advise if I'm not coming through. In terms of the report itself, the PPG, when it was reformed, there was a chair in place, and unfortunately they have resigned recently, and there is a new chair in place with the PPG. Obviously, we're working with the PPG and the practice to ensure PPG membership is stable now, but there is a PPG in place with an elected chair currently. In terms of just going back to the point around lessons learned and was this to do with COVID, certainly COVID was an exacerbating factor in all of this, and I think there are lessons to be learned which we're already sharing with practices across the county and certainly across the locality in relation to this, in relation to particularly around medicines management and long-term conditions reviews. And Lakeside actually have been very supportive with that and have been communicating directly with practices to give them the benefit of their experience. There's a wider issue, I guess, in terms of how the CCG can support practices through situations such as the pandemic. Obviously, we weren't expecting to go through a pandemic, which is stating the obvious, I appreciate. But we are reviewing lessons learned and restructuring how we support primary care going forward and into the new ICS. So I think there's work to be done on that, which we're picking up.
Okay, thank you. I've got Councillor White next.
Thank you. I wonder if you could tell me something about this automated system. I've spoken to a resident in Stamford who says that they couldn't get through on the telephone, and then they were referred to an automated system on the website which gave automated response to the issues, and they were told to take some paracetamol, and there was no follow-up. So what is this automated system on the website, please?
That's more detail about the telephony system, Nick. I don't know if you can answer that.
Yeah, some practices operate online consultation systems where if it's a straightforward piece of advice, people can access that advice via websites. I'll need to look into the system Lakeside have put in place in a bit more detail. I'm happy to come back once we've had a chance to look at that. In terms of the systems that Lakeside are putting in place, we're aware that they have a ringback system, and it may be that the initial query was reviewed by a clinician and they responded via email or by text message, which can happen through Ask My Doctor, Ask My GP systems. But we probably need a bit more detail on that particular patient's case just to understand what happened.
Thank you.
Thank you, Councillor White. Councillor Woodliff.
Thank you, Chairman. I suppose reading the report, I mean, my thing, I'm not involved in health anyway, previous to this anyway, but I was a school teacher for a long period of time, and you know that HMI can appear on the doorstep pretty well any day they like. HMI could turn up on the doorstep and say they want to inspect the school like that, and they can do it. Now I wonder, does CQC do that, or is it a more question of they'll appear at some point in time after having given the practice a fortnight to work things out? I don't know how it works, but I mean, I know that in the education, HMI, well, people are frightened of it, and it's a good thing they're frightened of it. I'm reading this report and looking at page 48, and it says that immediately after the Cqc inspection and prior to publication, the practice was issued with an urgent enforcement notice, a whole range of things here, and served 2 warning notices. So obviously, it's a very serious situation, and I'm surprised that CQC doesn't seem to pick these things up earlier. It would be better if these things were picked up early and dealt with, rather than they get to a serious head here. So I don't know how CQC operates, but I think there's a question mark about how CQC, how active it is, how proactive it is, shall we say, and whether it actually tries to pick issues up before they become serious ones. I don't know how the system operates. I'm sure that the experts can tell me much more about it, but it seems to me that it's a very much a kind of laissez-faire type of approach, whereby they kind of come in at the end, like the cavalry perhaps, And we need something which is much more proactive, because it's not right for patients to be in a situation where they are obviously dissatisfied. And most people don't know what to do in these situations. And it takes quite a lot of pressure from a large number of people to get these people to start moving. So perhaps the experts can tell me, how does the CQC operate? Does it have a lightning inspection process where it just walks into a practice and inspects it on the spot? Or does it wait for 3 mailbags of letters from people before it thinks about it? I'll leave it at that, Chairman. I think I'm being too provocative as it is, actually, so I believe it at that.
Do you want me to pick it up in terms of a short response? That they do have a CQC relationship manager that works with the practice. In this case, I think they were significantly concerned by the number of concerns that were being raised to them on an ongoing basis, and hence the inspection. But the CQC does have the right, if it is significantly concerned by any practice, to go in a point's notice. It's similar to school inspections in that regard.
You may come back.
Briefly, I don't think that's good enough, because this is a serious situation here. It seems to me that CQC and its maybe even the CCG have been very slow to pick up on this. I'm very concerned about the welfare of patients here. No, I'm very concerned about the welfare of patients here. That's my concern. I don't think the CCG is up to scratch here, or the CQC rather, is up to scratch. They need to be quick to move in here, because I'm very concerned about the welfare of patients. And to have 2 warning notices served, as it says on page 48, and other things here. It's very worrying. And I also look at page 51. There's a lot of stuff in here about, plans. I worry about those. I like to see actions. I'll leave it at that, Chairman. I'm being too provocative, I know. I better leave it at that.
Thank you. I would just say that the CQC are quite proactive. I know that the Health and Wellbeing Board, myself and Health Watch, we meet up on a regular basis. We all discuss if we think there's a problem area, and they will go in almost immediately. So I do think in this instance they had already inspected, as I think was said on the regime, that they do go around and inspect these various hospitals or trusts and so on. Unfortunately, somewhere down the line, something has broken down and it has taken for the public to get in contact. But I'm sure it would have been fairly quick after the public getting in contact. They would have gone in and inspected. And we have been told they have inspected again more recently. Of course, with the CQC, they've had their problems of inspections over the last 15 months because COVID has had an effect on them. And they haven't been able just to go in and inspect in the normal manner. So I think that that has had a knock-on effect. So that's all I would add. Thank you. We have Councillor Cleaver next, please.
Thank you, Mr. Chairman. I'd like to amplify, if I may, the comments of Dr. Wookey and Councillor Parkin in terms of the fact that lessons learnt are not appearing in this report. And living close to Lakeside, being actually a patient of Lakeside myself and a local councillor for Stamford, I'm very much aware of what's been going on over the last 2 years. And I know that a lot of people have expressed a lot of concern, and there's been a lot of anxiety and worry and inconvenience caused to patients over that time. And therefore, it's great to see that the CQC have acted. But the thing isn't over yet. The mention in the report of improvement is, in all fairness, anecdotal. We do not yet know the results of the CQC's follow-up inspection, which took place in the week commencing the 30th of August. And I hope that the CCG will report to us again to ensure and to tell us exactly how quickly improvements are being made, indeed that they are still being made. And I would like to know what the CCG will continue to do until Lakeside has got a good rating in Stamford. And coming back to lessons learnt, I think, Mr. Chairman, I would like to see a lessons learnt paper coming back to this committee. We really do need to make sure that this can't happen again in any other town in Lincolnshire. I think as a committee, that is one of our responsibilities, or I would see it as such. And so I hope we can, and I obviously welcome any comments that CCG members attending would like to make on that. Thank you.
Would it be okay if I came in here, Wendy?
Yeah, just as we could want to pick up the lessons learned, because I know we have been doing that in terms of pulling that together. So.
Yeah. So in terms of what the CCG will be doing until we're clear that matters have been rectified and the issues raised by the CQC have been addressed, we are going to carry on meeting with Lakeside on a regular basis to understand progress in addressing those issues and how Lakeside get evidence that those issues have been addressed. The CCG, obviously, we're keen to offer support to Lakeside in certain areas as well. So in terms of staff, management, governance processes, etc. So we will be working with them and bringing in colleagues from across the CCG to support Lakeside address those issues. So that's going to be an ongoing process until we're clear that those issues have been addressed. And obviously we'll be liaising with the CQC on those issues as well to make sure that CQC concur that all of those issues have been addressed and actioned. We'll also be meeting with the PPG, and I think Wendy touched on the PPG. Will be carrying out a survey and talking to patients. So I think it's really important that patients have a voice, and that there's a so what, if you like, that all of the actions have made a difference to the patients. The patients see a different service and a different level of care provided by Lakeside. So we'll carry on working with the PPG and the practice in that regard. Going back to the point around lessons learnt, the CCG was asked by the Primary Care Commissioning Committee to carry out a lessons learnt review of what had happened with Lakeside. This was mainly focusing actually on the issues around the premises and the proposed closure of St Mary's branch. but it did widen the scope a little to look at some of the other issues and patient complaints, etc. And that is being reviewed by the committee and by the CCG today. So I'm just waiting for the outcome of that discussion. I understand that a high-level summary will be made public at some point, possibly through the CCG's board. But what we'll be able to do is come back and advise this committee on that and make sure that any public version of that report that's released is made available to this committee too.
Thank you.
Okay, I think we've had a good debate on this now. I have Councillor Boston left to speak, and then I'm going to move to a proposal after a couple of questions myself. Councillor Boston.
Thank you, Mr. Chairman. You know, some members here know that I was a long-term member of this committee for some time. I'm seeing the same issues coming up now as we've been seeing for 5-6 years. And I'm hearing the same words. I heard the words issued by the Lincolnshire Hospital Trust. I heard the same words issued by TAS. I heard the same words, I'm hearing the same words issued now. I've heard them many, many times. We have plans. Well, I'm sorry, but we have plans doesn't wash with me, and I'm afraid it doesn't wash with members of the public either, but members of the public are paying. When I look at the management of these companies, because the doctors' surgeries, the doctors' practices are private companies that are contracted by us to look after us. And when I see that something has been running like this for several months, several years, and they all of a sudden start to get plans, I want to know what we are really doing about it, what we, the paying public, are doing about it. I know for a very clear fact that several of the senior managers, senior partners of these practices are earning in excess of £300,000 a year. Why aren't we hitting their pockets, reducing their... When we find a problem like this that isn't being identified, that isn't being addressed at all, and then we have a plan that's going to take months, why aren't we taking some of the money from the practice and making those people who are supposedly managing it feel it in their pockets? We're hearing here that there are management issues with this place. There are significant management issues. Don't blame the foot soldiers. It's the management, and the management should be hit. I know of at least one other practice within this county where there are significant management issues and nothing is being done. Nothing, no, I'm not necessarily saying we can do it in Lincolnshire, but I think this is perhaps something that should be addressed to the Secretary of State to say these managers, these private companies aren't doing their job, and they're taking enormous salaries out of it, enormous salaries. And I would like to see something in that line done, and I would like to ask the people who are here to talk to us today what they intend to do to ensure that those plans are not just plans that are put into place and spoken about, but we want to see them acted on. I don't see why they shouldn't be acted on within 7 days. If there's a serious issue that they should have identified a long time ago, we want immediate action, not plans that may happen in the future.
I think maybe just to reply to that in terms of the CQC visit, if there were any immediate actions that needed addressing immediately, then they were put into place within the time frame that was required. For the action plan that is in place, we have agreed a sensible, in terms of the issues that need to be resolved, sensible time frame in terms of when we expect the issues to be resolved, and we will be monitoring the practice against those agreed time frames. The leadership issues, indeed were leadership issues identified for this practice, and they do form part of the action plan in terms of areas that we need to see improvement and demonstrated improvement. So that will be monitored through our processes, which, as Nick said, you know, we are meeting and having discussions with this practice regularly, and also doing quality visits into the practice where needed, and quality officers are assisting in certain areas where improvements are required. For example, we've assisted in terms of safeguarding training, and also in infection prevention and control systems and processes. Just in terms of where the practice have asked for additional support that they've not been able to facilitate themselves or obtain from their sort of wider Lakeside partnership.
If I could just add, Wendy, if I may, Chair, I guess one of the issues has been, one example of one of the issues would have been people who require blood tests to check that their medication is treating the condition and is safe for them. That was picked up by the CQC. One of the things the CQC is able to do is to go directly into the practice's clinical system and see which patients have had reviews and have had blood tests, and what the results of those blood tests are. And as part of the review, CQC will have looked at that, and when they were inspected, will again have looked at those systems to assure themselves that those reviews had happened. So again, I think that's an example of where, and I understand the councillors and the committee's concerns around, you know, whether this is just a plan or whether something's actually happened, but the CQC will have looked at that and will have assured themselves that the steps that were required have been taken. And it's something indeed we'll be picking up again with our discussions with the practice and the CQC, so we can be assured that it's not just a plan, it's not just words on the page, but actual action has been taken to improve patient care.
Councillor Boston, you'd like to come back if
Yes,
it's only
please.
short, please.
I don't wish to I don't want to call names against the people that are speaking or the CQC. That isn't the issue. They are doing what they do as well as they can. My issue is with the fact that these issues, it's gone over now for many, many years. We're not talking about something new, and we're not talking about something new in doctors' practices. Most of us will remember the closing down of a practice near to Skegness because of the similar problems. Actions weren't being taken. And we don't seem to be learning any lessons, and we don't seem to be doing anything positive. We find a problem, we make a plan to deal with it. We do something. But I'm looking here, are the services safe? No, they're inadequate. Are the services effective? No, they're inadequate. Are the services responsive to people's needs? No, they're inadequate. Are the services well led? No, they're inadequate. I'm sorry, these are issues that are clear to anybody and should be very clear to the management. And it's about time that we, as a society, looked at the management of these companies. If it was any other company, other than one that was being fed by the monies that we're paying in, then the management will be suffering. And I very firmly believe that the management should be hit in the pocket with this, because that's what they feel the most. If they were being hit in the pocket, and retrospectively, if they've allowed it to happen, then we might get a better service. We need to be looking at taking positive steps, and we've not been doing so for, well, 7, 8 years to my knowledge of service on this committee. It's I think we need to be doing something. I don't know what, but I certainly think that we need to be doing something. My suggestion will be to look at the contracts.
Maybe if I just come back, it might not answer your point in full, and I appreciate what you're saying. But with the CQC inspection regime, if they are assessed as inadequate, then the CQC will go back in short term in terms to do a full review inspection. They did have a further visit last week, but that was to make sure that they were making progress on the enforcement action and the particular warning notices that were served. But the CQC will also go in and do another full inspection and make again an assessment. And the process of CQC inspection does give a time frame for achieving improvement in terms of actions that are required. And that's the period of time that we're in now. The practice of being given that opportunity to make the improvements that are needed. So if the CQC went back again and was unsatisfied, then yes, they could deregister the practice, and that would initiate contractual action on the part of the CCG.
Thank you. I think one of the big issues we've always had as this committee is we can't see the contracts. These are not things we're privy to, because of course there is that privacy between the practices and so on. And I think when we've asked, it's always been a very firm no, we can't look at those. That is a difficulty, because I'm sure that would be very enlightening. I think it's also very interesting whether or not, a little bit like with our tassels and so on, whether there's KPIs and penalty points that are taken against our GPs, because that's something that doesn't ever seem to come out. I don't know whether or not our people from the clinical commissioning group can advise whether these sort of things are within that contract or again under privacy if that's not something that they can disclose.
The standard primary care contract is a kind of a national document, and Lakeside operate under that. For the vast majority of their services, there are a couple of exceptions to that, where the CCG locally commissions services. In terms of the general contract, there aren't kind of penalty clauses, so to speak. So there's kind of a core contract with requirements in that, and kind of payments, to as part of that contract. The key, I guess, the key issue is CQC regime and contractual enforcement by the CCG, but that wouldn't include a kind of a financial penalty, particularly over the COVID period. I guess it's worth noting as well that GP income or primary care practice income was protected over the COVID period, really to support primary care resilience and support them being able to carry on delivering services during a challenging time. So sorry, that's a slight tangent, but just something I thought worth noting.
Okay, thank you for that response. I do think, and I understand that our colleagues in the NHS have been under severe pressure over the last 15 months, and I certainly wouldn't want to have been in their shoes. However, there does seem to be quite often now an element of that the pandemic is blamed for everything, and I think trying to move away from that now would be beneficial to our residents. I have a couple of questions before I'm going to move to a proposal. And my question is, it is just over 2 months since the CQC inspection, but what does the CCG anticipate might be the outcome of the re-inspection within the next 6 months, please?
I think in terms of the practice feedback from the recent revisit by the CQC did note that improvements had been made in those major patient safety areas, but there are still improvements to be made in the other areas, and I think that's the feedback we've received from the practice so far. I think the re-inspection in 6 months, hopefully, or within 6 months, sorry, not in 6 months, will hopefully demonstrate that continued improvement and the achievement of most of those actions that have been put in place.
I think worth adding as well that we've seen a positive response from the practice as well in terms of wanting to address the issue, certainly talking to the local clinical team in the practice. So I think that gives me personally some confidence that the practice will address the issues. Still a bit of work to do, as we've discussed, but I think they're very keen to address all these issues and really get the practice back on an even keel again.
And in the just to add to that point, just from the beginning, they have been very receptive and eager to engage in terms of ensuring we're aware of what the issues are, informing us how they're going to address them, but also where they've got areas that they want additional support, they've been very receptive to receiving that additional support from us.
Okay, thank you. And my second question is, what does the CCG think are the biggest challenges for Lakeside in the coming months?
I think it's still the staffing pressures in some of those particular areas. I think the nurse staffing they need to address. They have made significant progress in terms of GP staff numbers, the 3 additional GP staff. And I think it is that relationship with the public, improving that relationship with patients and the public, making sure that the concern and answering of concern processes are robust. And also in terms of I've just let Nick come in because I was just thinking of something else, but it's gone out of my head. So you can come in there, Nick, if that's okay.
Yeah, no, I think those are the 2 key points for me, Wendy. I think it's really around clinical capacity within the practice and ensuring they've got the staff and the time to be able to care for patients. And as Wendy said, there's been significant improvements. I think another GP joining in December as well, on top of the 3 that have been recruited recently. So again, that's positive news. Winning back patient and public trust, and I think also addressing the relationship with the CCGs. So that's kind of a slightly parochial of me, but I think just generally, particularly importantly, winning back trust of patients and the public. And I think there's been some good progress in terms of the communication campaign they started through the local paper, the Stamford Mercury, where there've been a couple of articles, and the PPG have got involved in that. I think that goes some way to start to address that, but that's an ongoing issue and a challenge for them.
And I think the other one, just reminding me as Nick was speaking, was that making sure that the staff are supported and the well-being of the staff as they move forward, particularly where they're facing those capacity constraints.
Okay, thank you. In which case, I'm going to move to the proposal. I would like to propose that that we record the committee's concerns with the standards of care provided by the Lakeside Medical Practice, which has led to the Care Quality Commission's rating of inadequate. I would also like to request for the committee to receive the action plan and the lessons learned, and to note the actions taken by Lakeside Medical Practice to date in response to the inspection, and seek a further update to the committee's January meeting. I'd also like to ask for our regards to be passed on to Andy, and we hope that he gets better soon. So, do I have a seconder to my proposal? Thank you, that's seconded. All those in favour, please show. Thank you, that's supported. And I'd just like to thank our speakers for presenting today. Thank you.
Thank you.
Okay, so I'd like to now move over to agenda item 6. Yes. Yeah, Councillor Cleaver, sorry, you wanted to come in before that.
Apologies. Could I just make a request that, given the poor sound quality of the CCG people there, that we consider making sure the subtitles on the published version on YouTube? Thank you.
Yeah, I think we can look into it. I'm not sure if it's something that could be possibly done or not, but we can ask a question certainly. Thank you. Okay, anyway, moving back to where I was. Agenda item 6, Community Pain Management Services. You will find this is on page 53 to 58 of the agenda pack, and our presenter from the Lincolnshire Clinical Commissioning Group is Sarah Jane Mills, Chief Operating Officer for the West locality. Welcome, Sarah Jane. If you can just present for around about 10 minutes, please, and then we'll take questions at the end. Thank you.
Thank you, and good morning, everybody. You've got in your pack the information report. I'm just going to, as usual, highlight a few points. You previously considered a report at the committee in March of this year, and prior to that, a number of other reports. In terms of some of the key points that we've discussed at recent meetings, the re-establishment of services following the COVID-19 pandemic. I can provide an update in addition to what's included. 14 of the 15 clinic sites are now up and running again and offering patients to attend face-to-face appointments. The 15th, which is in Louth, there will be a slight delay with that being re-established in October. The reason for that delay is the facility they were using is currently being used to deliver COVID vaccinations. So they've had to find an alternative and they will be relocating to the Louth St Barnabas Hospice, which is just on the outskirts of Louth. In terms of quality, I won't go through all the information because it's there, but I would draw to your attention to the fact that the organisation were inspected by CQC in May of this year and received an overall rating of good. In terms of complaints and patient survey, you can see there is a changing trend in terms to improvements in terms of both of those areas, and that the company are aiming for an upper limit of 2 formal complaints per 1,000 patients, which was achieved for the quarter up until June 2021. In terms of performance indicators, at the previous committee, it was noted that there was a significant delay from referral to assessment of 40 days. The information attached in the key performance indicators shows that there has been a month-on-month improvement, and now that they are achieving 87% of that against a target of 90%. There has, though, been a detrimental knock-on effect with regards to service users being able to access treatment from the date of decision, which should be within 18 weeks. Currently, it's within 26 weeks, but the plans are in place and we anticipate that that will improve in line with their action plan over the next 2 months. One of the other points that was discussed at the previous meeting was with regards to the time taken from referral, requesting an individual funding request, and this is for a treatment that is not routinely commissioned. The timeline for that is within 30 calendar days, which is the standard framework that we operate for individual funding requests. And then finally, one of the primary drivers for introducing a community-based model that was designed in line with the best practice recommended by NICE and the British Pain Society was with regards to reducing the use of opioids in Lincolnshire. Whilst it's recognised that prescribing data that we receive is very, very complicated, there are 15 measures used which provide us with an insight. And whilst 12 of those show a downward trend, 3 which are related to the prescribing of pregabalin and gabapentin, there is an upward trend for Lincolnshire and nationally. We obviously are concerned about making sure that the prescribing of both those is appropriate, because they are quite addictive drugs. And so our prescribing team is working both with the community pain service, but with general practice, who may also be involved in prescribing those treatments, to actually make sure that we bring that closer to the national best practice, and make sure it is relevant for patients. Just for clarification, those 2 drugs are used largely to treat pain. They can be used for treating epilepsy, but we believe that the majority of that activity is pain related, and therefore we continue to commit to encouraging general practice to make best use of the alternative model provided by the Community Pain Service. So I think those are the headlines that I wanted to present today.
Thank you, Sarah Jane. Okay, we'll open up to questions. Councillor Parkin.
Thanks, Chairman. I think I'm very, very aware of the impact of chronic pain on mental health, and then how that can spiral into, knock-on problems like musculoskeletal problems, and it's very easy then to spiral down in that spiral of pain and mental health and more pain and so on and so on. What concerns me, although it's reassuring to see that the targets are being met, I have a real issue with the KPIs themselves, because if you add on the 40 days to referral to then the 18 weeks to treatment, you're talking about 24 weeks, you're talking half a year of people being in chronic pain who would have been in chronic pain way before that, because you don't go to your doctors most people don't go until they really need to. And we must be in a position where, because we are not treating people earlier, we are then having to push them not only into more physical and mental harm's way because of those KPIs being so low, but also more expensive and more invasive forms of treatment, and more complex treatments. And so I recognise that, it's great that KPIs are being met, but that seems an incredibly low bar to be getting over. I mean, what is the answer? Do we need more financial investment in this? Is there not the capacity to get people through quicker? But for me, that is a fundamental problem here, that these wait times are being hit, but these wait times are just way, way, way too long in the first place.
Do you want me to respond?
Yes, please, Sarah Jane.
So thank you for that. The KPIs are actually the national KPIs. So those are the ones that we work with in terms of evaluating the performance of planned care services, this is. So firstly, just to clarify, they aren't indicators that we have designed ourselves. They are the national targets. I would agree with you in terms of people living with the challenges of sort of like chronic pain. And it is for that reason that the Connect Health Service does have alternatives in terms of being able to connect people into other support services. So you've got attached in terms of information around the flipping pain service, which again helps people to think about how they psychologically manage this. I think at this point in time, our focus has to be making sure that we are achieving those national targets. That has to be our minimum threshold. Clearly, as we move forward, we would want to see that we're exceeding those national targets for exactly the reasons that you describe.
Thanks for that. I'm really, really, really profoundly disappointed to see that as a national response, and that they are national guidelines. Chairman, is there any way that we can, as a committee, express concern at those national guidelines somewhere, and send a letter off? Because I wouldn't. I did once have a injury from an RTA that left me in chronic pain for years, and it was the most horrific and miserable experience that I think I've ever been through. And I think for nationally, for the bar to be that low, it's nothing short of a scandal. What does give me a little bit of hope and a little bit of encouragement is that we do have the aspiration in Lincolnshire to get better times than that, and I would like us to honour that progress and see how we do with that, because that isn't good enough for anybody.
So just to clarify, those national targets are the national targets for planned care, of which pain is one of them. So it's not a specific national target for pain, it is a national target for planned care. Of course, as I've described, our aspirations have to be to bring that sooner. I think the other thing I would highlight in that, because there are three stages to this in terms of patient waiting time. So there are the issues of people living with pain and not seeking support from their GP, and the time which obviously is within, can often be quite a long time because people think it will get better. Then I think there is the second issue, which is when somebody goes to the GP, which is why the focus actually on the opioids, which I know may sound like a bit of a strange thing to say, but actually the focus on the opioids and showing that we're over prescribing those, and actually helping our GP colleagues understand there is an alternative, that with the community pain service, which does offer an alternative, would in some ways expedite their referral into this service. So whilst the referral to treatment and the decision to treat targets are nationally, there are things that we are doing that I think will expedite people getting into that service sooner. And then, like I say, our aspiration has to be to exceed those national targets.
Okay, thank you, Sarah Jane. Just in terms of national guidance wise, I think committee wise, we sort of get to be involved in these when they go out to consultation. Other than that, it is obviously something that is nationally set, and although I'm sure we could raise our concerns, how far that would actually go, I would be quite concerned around. Yeah, absolutely, I wouldn't disagree with you. Thank you. Councillor Woodliff.
Thank you, Chairman. Well, I suppose the 3 points really, I suppose, with pain management, the important point is whatever's prescribed has to be effective. I'm worried about these kind of, trends and proportions of patients and so on, have this, that and the other. There's no point in supplying something that fits in with the national averages, which actually is ineffective again in dealing with the original issue. So whatever's prescribed has to be effective. And that's one of my concerns. The second thing is that this is about 1,000 patients. Well, people will set up in Berkshire to come and live in Lincolnshire because they can retire to Lincolnshire. So the population in Lincolnshire is probably slightly different from the population in Berkshire or, sorry, my own health problems actually, I apologize about that. So you've got, it's not reasonable to make a comparison of per 1,000 patients for Lincolnshire as it is for Surrey or Berkshire, whatever, because the populations are different there. So that's what worries me also. So there's a kind of national average applied, but the national average wasn't relevant because national aspects change from where you are. And the third point, which really relates to the previous item, I suppose, really about access to GP practices and being able to get an appointment. That's a really serious issue. And when we're going through all the stuff with Lakeside, I'm thinking about another practice, which is going on. So, it is a very, very worrying report, really, I think. Chances are that if you do manage to get an appointment with your GP, it won't be a GP you see, it'll be the nurse practitioner or something like that. So I'm very worried about all of this. I'm worried about the effectiveness of whether or not what is being prescribed to fit in with national guidelines is actually going to be effective in dealing with the pain, which is the key issue. I'm concerned about the stats because I don't think that's relevant. What's per 1,000 patients? So say like up the coast, for instance, 1,000 people mainly about my age, as opposed to be in Berkshire where they'd be much younger. And then, of course, it links in with the access to the GP practice, being able to actually get the appointment, to get on the system, to be able to get all these things that you pay for, the things that we pay for, free at the point of delivery, but it's not free when you're paying your income tax. So I think I'd better leave it at that.
Yeah, thank you. Just in terms of GP practices, we do have an item on next month in terms of access to appointments. I think there is a valid point here that you do need that initial referral in to then get into the community pain management, but I don't want to go too far down the GP side of things in this particular meeting and at this point.
Well, I really raise it because of the previous
I take on board, that's what I said.
It is a relevant issue. Yeah. Thank you, Chairman, for your advice.
Thank you.
Anyway.
Sarah Jane, if you'd like to try and answer.
So in terms of outcomes, you are absolutely right. This is about making sure that the treatments match the needs of the individual. What I would refer you to is that in terms of the April to June data, 85% of people who did respond had positive feedback, and within that, it is about that the outcome had improved for them. So we do very closely monitor the outcomes. One of the issues that I think we have discussed at length and links to the opioid prescribing is that ironically, because they are quite addictive drugs, that the dependency on those drugs can mean that you become conditioned to them, which is why this model that we have looks at a combination, and there is strong evidence that that combination does improve outcomes for patients, and I think we are seeing the evidence of that from the feedback from patients. In terms of the data and the evaluation, the per 1,000 patients was related to complaints. So what they were, what Connect are aiming for is being realistic in terms of there sadly will be occasions where people feel the need to raise a formal complaint, but they want that to be as low as possible. So per 1,000 patients was in reference to that and to formal complaints. In terms of the benchmarking around other things and particularly in relation to opioids, you're absolutely right. Benchmarking is just one tool, and you can be better than somebody who is actually not very effective, but also you can be better than or worse than somebody that actually has got a different requirement. In terms of the work we are doing with colleagues from public health, we are moving much more to a framework which is called population health management, which will very much focus on the individuals living within a population and looking at what the data says in terms of our effectiveness of managing and treating those. Now, that is quite a change for the NHS in terms of historically we've been much more biased to using performance indicators, and as was highlighted earlier, performance indicators don't always achieve or support the right outcomes. Population health management will enable us to really understand what are the needs at a sort of like Lincolnshire level, at a local primary care network level, and on an individual basis. So we will be able to look at individuals and notice whether there is a trend, particularly in relation to something like pain, where pain can be exacerbated by a whole range of things. But also it will enable us to determine, as you highlight, that in certain areas of Lincolnshire, we may have more people living with a higher prevalence of chronic pain, and therefore think about how we shape services to respond to that local need. So we're on a journey in terms of data, and I think you're absolutely right in terms of making sure it's relevant to our populations, and that's work we're doing very closely with our colleagues in public health. I take on board what has been said in terms of general practice, and will defer comments around that until the next meeting.
Thank you.
Okay, thank you. Councillor
Thank you
Woodley.
very much. Thank you.
Yep. Okay, I have Councillor Cleaver-Brown.
Thank you, Mr. Chairman. Well, I'm not at all happy about this report. In fact, it beggars belief, some of the stuff that I've been reading. And I will refer back to this paragraph regarding use of opioids. I was told only 2 weeks ago by someone in the medical fraternity, because I do know quite a few people there, that Lincolnshire is recognised throughout the medical fraternity as the worst health authority in the United Kingdom. Pain relief injections have been taken away from patients who would have at least had somewhere in the region of 6 months pain relief. Now, working it out, if it's financial, and for goodness sake, let's hope it isn't, 6 months of severe pain for saving some money is not, in my opinion, acceptable, and certainly shouldn't be by this committee. Pain clinics we go on to. Well, dare I say it, they're inadequate, they're useless, and in some instances laughable. I have myself attended pain clinics, and it really works out that you get quite a few group of people together and suggest that they mix as a small fraternity, discuss their pain, have a cup of tea, a cream cake, and perhaps find something funny about it. Well, yes, it can be funny if somebody's walking with 2 sticks at one point, and suddenly, when pain relief is denied, they suddenly have to go on crutches or a wheelchair. I don't consider that's any use at all. Pain clinics have this idea that you can manage pain by feeling happier, by having a good laugh occasionally. Well, anyone who is at all suffers from any invalidity has to have a sense of humour anyway, just to get through life. We in Lincolnshire, and I do want to ask this, Mr. Chairman, because I'd like to know how much all these committees cost that we've got. The CCG and the CPMS and somebody else, all looking into problems. They meet, they've got officers in charge that report back. We are paying all these officers. At this rate, from my point of view, if we did away with all these interfering people and were able to just get on with it with one person in charge of this committee and that committee, we may even be able to open Grantham Hospital A&E again. Sorry, that's a pun I shouldn't have put in. However, I am very, very worried. I'm also worried about this paragraph on opioids. Am I to take it that do you wish to take patients off pregabalin and this other drug just to see how much more pain they can stand?
Yes.
This is what we're down to, and this is me speaking as I always have done, point for point. I don't consider taking pain relief away from patients is in any way a good thing. It cannot be. People can live their life, they can continue to be active, and they can continue to be happy to a certain degree. The councillor that mentioned the mental problems that comes with pain is quite right. Young people, we never want to see in pain if we can help them, and give them as much pain relief injections as is possible to make sure that they can live with it. Older people are expected to live with it. But to start taking away some of the pain relief, whether it be in tablet form or whatever, is not on. A 60-year-old person I know who was extremely active when she used to have 2 injections a year is now on crutches. This cannot be right. And it cannot be right that Lincolnshire is the only county that doesn't allow it. Now, at one time, when this first came in and pain relief clinics came up, about, I suppose it would be before COVID or as COVID hit us, it was accepted by Northamptonshire, Cambridgeshire, Nottinghamshire, Leicestershire and Cumbria will all try to have pain clinics. They have all accepted, and I know this on good authority, that they're not saying pain clinics are no good, but they're not supporting them the way they had to before, and they have referred back to using evasive injections that some patients need. And therefore, if we want to up sticks and move into one of these other counties, we may well get those pain relief injections back. Now, I know that Lincolnshire has got a far larger occupation of older people. You're quite right, they've moved from the... All right, right. The question is, the question is really, does this committee really, really, truly believe that it is better for people to suffer chronic pain than to do something adequately about it, like recommending that the pain relief injections or come back? I'm sorry, that's my question.
Would you like me to respond, Carl?
Yes, please, Sarah Jane, thank you.
Firstly, thank you for your comments. Just a number of points. I haven't heard the feedback that you've highlighted in terms of we're the worst health authority in the country at all. And if you would like to send me any further information that has highlighted that, I'm happy to investigate that. Secondly, in terms of the model that we have adopted in Lincolnshire, there's 2 parts to this. The first is it is absolutely in line with the NICE guidance and the British Pain Society's recommendation. So this isn't something that Lincolnshire has just developed on its own. We have adopted the best practice as advocated by those experts. And thirdly, it is not the case that people cannot get injections. They are able to continue to access those injections where it is clinically appropriate. And what we have highlighted in this report is that where people are starting that treatment, there is a extended delay, and that's something we want to address and improve. But actually, if somebody is already on a treatment regime, there is no delay. So in terms of that, and they will. So I think there has been considerable concern about the fact or perception that those treatments aren't available, but they are available where they are clinically assessed as appropriate. In terms of the opioids, obviously it is important that we look at the sort of like whole person, and that the clinicians who are the experts, along with the patient, make the decision about whether a patient wishes to begin taking treatments that, as I've explained, are very addictive and are likely to lead to an increased requirement over a period of time, or whether we should work with them in accordance with the best practice and look at other ways of managing pains. So it is important that we look at that, because there are clinical risks of taking these two medications, as there are in terms of other aspects. And finally, whilst I do absolutely acknowledge your feedback, I would draw you back to the fact that the feedback that the organisation has received, and we can only work on the feedback that patient provides us, does indicate that it was positive, and we have seen that improve over time, and that it is our commitment to continue to see those improvements. But fundamentally, the model that Lincolnshire has commissioned is absolutely in line with the national best practice and the expert advice, and was developed, the specification with for that service was developed in partnership with representatives from those organisations. So we are adopting that, and where people clinically need pharmaceutical interventions, then they will receive that. And that's why it was very important for the committee to understand what the delay was in terms of individual funding requests, which hopefully we've answered.
Thank you, Sarah Jane. Councillor Woodliff, would you please switch off your microphone? Thank you. No, that's fine, not a problem. Thank you. I've got Councillor Boston now.
Thank you, Chairman. I would like to know what the trigger points are for the KPIs. When you're first sent to a pain clinic, what is the first turn-off point to say that the KPI has been answered? Is it the time when you go to see the stage show where somebody stands on stage and tells you what pain is? Because that doesn't do anything for anybody. Or is it the time when you go some 3 to 4 months later to see a physiotherapist who just goes through the form that you've filled in twice already, sits 6 feet from you, doesn't touch you, and then says, I'm going to transfer, get you an appointment with the consultant in charge of the pain area? Or is it then when the consultant telephones you and you get a first contact with somebody who is going to do something? I don't think we're hitting the KPIs, because if it's the first point when we go to the stage show, and that's all it is, it's a stage show with 3 people getting up, flashing you something on a screen and telling you what pain is. I don't think there's anybody sat in this room or anybody that's sitting out there listening to what is being said that doesn't know what pain is. If you stick a pin in your finger, it hurts, and it's called pain. So I think we're missing those KPIs. Also, you talk about assessing the kind of treatment that people need to control pain. There's no discussion, or certainly in some cases that I'm aware of, there's been no discussion about the side effects of the medication and the impacts it would have on the occupation, the jobs of those that the people are on. I hate to bring my own case into it, but in my case I was given amitriptyline, which meant that I couldn't properly stand up and gather my thoughts to defend clients in court. It was affecting my mind. The simple answer to that is stop taking it. We can't do anything more for you, go away. That isn't a pain management system. That's a complete rejection. And Sarah Jane, you will remember that I had to telephone you personally because I was being told lies by the doctors that they hadn't had a referral. And that's several years ago now. And strangely enough, they told me that although they hadn't had a referral, they'd sent me a letter out the day before, which didn't arrive.
If I try and answer a couple of the points there, in terms of clarification, the initial assessment is when you are reviewed and seen by somebody. So it isn't the attending the paying presentation. That is not an initial assessment, because that is an information giving. It is not an information gathering process. So the initial assessment is the first contact, which will be, as you've described, with the physiotherapist, who will then review that and make recommendation in terms of whether you require physiotherapist or whether you do need a review by a consultant. In terms of the point you make about medication, that is largely what we are trying to advocate here, and the model we have commissioned, which is why we do encourage GPs particularly to make referrals to this service so that we can look at that holistic view, is exactly the consequences of taking some of the pain relief, amitriptyline being one of them, and you've described that, but the two that I've referred to today can be quite significant on a person's life, and it is very important that people understand that. I would hope, but if you're telling me otherwise in terms of individual experience, I would hope that in a consultation with a consultant, they would provide you with all the information so that the patient can make an informed choice. If not, then clearly we can follow that through. And with regards to your final point, I think we've been very open with the committee that as we transitioned into this new arrangement, there were a number of logistical problems, such as that you described. Those logistical problems I think are now very few and far between, and that it was, on the back of the feedback we had, that we worked with Connect to make sure that they had much better systems and processes in place. So I think they were a legacy issue at the point of transition. I don't believe there's such an issue now.
Thank you, Sarah Jane. I still have a list of free speakers, and I'm going to close the debate down at this point. I'll start with Councillor Cleaver first, please.
Thank you, Mr. Chairman. I just meant to make the comment in terms of how commissioning has worked in case of the pain management clinic. First of all, as I understand it, the original Connect Health contract accidentally left Stamford off the contract, and that was then later corrected. But we now have a situation where there is a pain management clinic run by Connect Health in the town, in its own premises, open only on a Thursday, away from the hospital. Simultaneously, the hospital has a pain management clinic, but it's not available for Stamford patients. This is one of the issues that we have, being on the border of, in fact, 3 CCGs. And it's an issue which is obviously frustrating to local people because, on one hand, you can say that this is an inefficient use of resources because you've got 2 pain management clinics in one town instead of just one. On the other hand, you could say it could enhance patient choice and patients could actually be better off maybe than people elsewhere in Lincolnshire because they could have a choice of 2 pain management clinics. But that doesn't work, of course. So I'd like to flag that as an issue which is in our minds about the issue of clinical commissioning within a border area. and obviously in the context of what's going to happen under ICSs. So I'd just like to flag that one to the committee, please. Thank you.
Thank you. Just to say, I think your points you make are very relevant in terms of commissioning of services for people who live close to the borders, and we do take account of that in terms of commissioning, and we'll continue to as we move into an integrated care system. And we will, of course, work with colleagues in other integrated care systems as we do today, where there is evidence that it is better for a patient to go out of county to receive the treatment. In terms of the original contract, it wasn't accidentally omitted. There was a conversation about whether patients from that area would continue to access the services in Peterborough. And at one point in time, it was agreed that that would be their referral pathway, and that would be where they would access their treatment. As we went through the process, there were further discussions, and it was concluded by both parties that it would be more efficient to have a local clinic in the Stamford area that offered the services. And I think those sort of conversations will feature as we go forward, and there will be multiple issues that will be taken account on in terms of what is the best needs for the population, and how do we best meet those, and how we serve those going forward. But I think it's an important part in terms of ensuring there's visibility of that for you as a committee and for local people.
Thank you for the clarification. Obviously, I hope that such discussions in future will be subject to scrutiny and carried out in open.
Absolutely, absolutely.
Thank you. Dr. Wookey.
Thank you, Chairman. First of all, I think it's worth reflecting on the fact that overall, as far as Healthwatch receipt of comments is concerned, that the numbers coming to us have greatly reduced over the last 6 months. So somebody must be doing some good, because I don't think it's just patients acquiescing. However, there are, I think, some items that are still perhaps not being addressed as well as they can be. And some of this comes back from somebody in my village who cottoned on to the fact that I was on the board of Healthwatch and contacted me, and I've passed his comments into our system, but he is actually somebody who's well able to speak for himself direct, and indeed has done. But he outlines the fact that he had 9 contacts since the beginning of 2020 with the service, and only one of those was a face-to-face. Now, clearly that was a lot to do with COVID, but nevertheless, the fact that when he did have a face-to-face consultation and he was examined properly, within a relatively short time, he did have a nerve-blocking injection in his spine. So again, they're certainly not dead in Lincolnshire, but it took a lot of time and a lot of people. And I think what comes out of all this is that the follow-up system doesn't appear to be working, in the sense that he had this injection which wasn't effective, unfortunately, but there was no follow-up arranged from that appointment and that consultation. So he then went back and said that it unfortunately wasn't working. So he appears to have gone back on the old waiting list. So rather than being followed up to be seen to see whether it's worked, he's gone back onto the waiting list, which doesn't seem effective. So that's another, whatever it is, 18 weeks waiting, which, you know, is not a way to run a continuing service and provide continuity of care. So I think there are communication problems within the service. The second thing I wanted to just raise, because I'm not really sure about this, since it became a community pain control service, pain management service, are referrals taken purely from primary care, or are they taken from ULHT as well? Because if my memory is correct, and it's some while since I retired, but I can recall that most of the inappropriate referrals that came to the old pain clinic actually came from colleagues in ULHT who, instead of referring back to the GP, got fed up with seeing the patient and referred them on to the pain clinic. Now, I don't know whether that is still going, but that is partly what blocked the old system. And if that isn't so now, what happens to patients who are in ULHT clinics if they have pain problems that are not being controlled? Thank you.
Thank you, and thank you for the feedback that you too are seeing a reduction in people feeding back that their experiences have not been good. That's encouraging because it's obviously consistent with the data that we've got in front of you. With regards to face-to-face, I would agree with you, Dr. Wookie, that that is too long. I took on board Carl's point earlier in terms of we can't blame the pandemic for everything. But I do think the reality of the fact that the period of time you were describing was in the pandemic, it's likely that that created that situation, which clearly was not ideal for everybody. And I'm much more confident now that we've got, as I say, 14 of those 15 clinics back up and running, and the 15th on its way very soon. So I'm confident that we won't have a repeat of what you're describing. With regards to follow-up, I will take that back specifically. That's really helpful feedback. My understanding of the process, but clearly it hasn't worked in the case that you're describing, is that the service model is about patient-initiated follow-up, so that if the patient, rather than just the traditional of turn up for an outpatient for you to say to the consultants everything's fine, we are moving much more to a position where the patient can contact the service and say things aren't fine and I need a review. So in one way that's positive, but we need to make sure patients understand that. What I wouldn't expect, which is what I will specifically check with colleagues, I wouldn't expect that patient then to go back on a waiting list. I would expect them to be expedited through because they are already in the treatment pathway, and they shouldn't be going back in terms of a waiting list. There should be the capacity, and that's the whole sort of like concept of having capacity that enables us to do follow-ups, but that being productive, as in being initiated by the patient and therefore using that capacity in a meaningful way, but it should be available throughout. So I will follow that up, Dr. Wookie. With regards to the consultants, yes, you are correct. Part of the issue in terms of a referral into the pain service, it was a consultant-to-consultant service when people weren't quite sure what to do. In terms of the links now should be in the main, where it's not an MSK issue, back to the GP, so that the GP can actually review with those patients more comprehensively and determine whether the pain service is the right service for the patient. Where it is obvious, and that will often be the case through the musculoskeletal services, then those consultants can refer directly to the Connect Pain. As part of the work that we do on an ongoing basis, and the pain service is just one element of it. We are continually looking at musculoskeletal services and in terms of how we can improve those. And colleagues may or may not be aware that one of the things that has happened and is continuing to happen is an introduction of first contact physios, for example, within general practice. So again, we have experts, and all of those things are designed to actually improve patients' experience and getting them to the right person first time, rather than potentially going into a hospital appointment and then coming out and going back to a community service. I think there is much more work to do on those new referral frameworks where we see people going into community services rather than into a more traditional hospital-based service. But obviously consultants can refer if they think that's the case. But thank you for the feedback, and I will particularly follow up the issue around the follow-ups.
Okay, thank you, Sarah Jane, and thank you, Dr. Wookey. Councillor Matthews for the final word on this one, please.
Thank you very much, Chair, and thank you very much for this excellent report. Can I say how pleased I am that Connect Health has been rated good? I just wonder about the anomalies. So, for instance, Louth doesn't have a pain clinic at the moment and won't have until October. And I want to read you a letter of complaint that's registered on local GP practice NHS website. From the start of pain, rear left side back pain, the practice were made aware on the 13th of June, but told only a phone call could be had. Weeks went on, so went looking for help to Louth and Skegness walk-in centres. No luck there, so finally, after a doctor at my local practice, 3 weeks on, he ordered an x-ray, but that came back with very bad wear and damage from my job in the bones, not what was causing the other pain. Then I got a call from another doctor who ordered blood tests, and out of the blue, I am now, I don't understand what this means, CKD stage 3, very good as I missed 1 and 2. Now I'm still waiting to find out what I need to do, as there is no cure until 68, end of this year, enlarged heart, and it goes on a little bit. So the second anomaly is, you've got a very good practice in Lincolnshire as graded, and I'm a good practice, and I'm very pleased with that. Dr. Wookey has referred to potential communication issues with inside the service. I think you've got potential issues of access to the service, and you have said that you are moving to a position where patients can contact you directly, but I'm seeing in my ward that that is not the case. Now, it may be that the GP practice is the blocking point because they are not an efficient practice, and we discussed that over Lakeside, and I'll raise that later on. But I'd really like some assurance that these are anomalies, and they just happen to be affecting my ward and Mablethorpe ward only, and it's a flipping nuisance, and we'll get Louth sorted out. But here's a man in great pain as going to a GP on the 13th of June, and you've told me that Louth Pain Clinic is not going to be open till October, so that's missing your targets, and I imagine he's not alone. Thank you.
Thank you. Just, I'm going to actually have to refer to Dr. Wookey here just so that it can help me. I understand CKD is actually chronic kidney disease. I'm looking for Dr. Wookey.
I'm not sure I can help you there, actually. I think it's probably referring to a chronic a skeletal problem, but I'm not sure.
Okay, so the first thing we need to do is check, and if you get the patient's permission, I'm very happy for us to follow that through. In terms of Louth, yes, I absolutely take on board in terms of the delay. Unfortunately, the pain service would have re-established in the Louth Hospital if it were not for the vaccination programme, and I'm sure that people recognise that we're very keen to make sure that we deliver that vaccination programme as rapidly as we can. And we've been very successful in that, but there has been in the Louth area a consequence that means there is a delay in terms of setting up that service. But I am very confident that that will be operational as soon as the team can possibly do that. With regards, like I say, with regards to the individual, I think they are now increasingly individual episodes rather than generic problems. When we previously came, we were very clear that there were a number of problems in terms of the logistics and the operational running, etc. And I think you can see from the evidence and the feedback we provided, and also the feedback from Health Watch, that there have been significant improvements made in those areas. And for that reason, like I say, if you want to get the patient's permission, I'm very happy for you to put them in contact with me, and we can review with that individual and see how we can support them. It may be that that if they need to access somewhere before October, when the local clinic's up and running, we can make arrangements for them to go to an alternative.
Thank you so much. There might be a slight misunderstanding there. I don't know this patient. I've just read the patient's concerns from the NHS website of the GP practice. And what I'm asking is one of the anomalies that if you have a poor GP practice that is not coping, the patients do not have access to the pain service, which is probably a good service because we've been told it is. But in my ward, the access is the issue. So yes, I can provide you with the details of this individual patient, but that's just an example of patients at this practice who can't access the pain clinic and haven't been able to since, well, for a very long time, but clearly dated there from the 13th of June. So I'd prefer, if you don't mind, that we don't focus on the individual, but on the issue that if the practice is not engaging with the pain clinic, how are the patients meant to engage with the pain clinic, especially when it's not open?
So I think in terms of the point you made in terms of the practice, of course, as I've highlighted, there is an interdependency in terms of timeliness of access, and if the practice either isn't utilising the clinical pathway appropriately, and we will know in terms of information and be working with those practices in terms of what we would expect to be their referral rates and what they are, and if they're much lower, that will highlight the fact that they're not utilising it appropriately. If and again, I won't go into this because Carla's highlighted that the discussion around GP access will be picked up at the next meeting, but clearly if there are delays accessing your GP, and there's problems in a practice, then that will have a knock-on effect in terms of if there's a delay of accessing the GP, if the GP is not then utilising the pathway as they should be, that will inevitably have an impact on the timeliness of the access for patients on the community pain service, which is why obviously from a CCG perspective, we're doing a lot of work with our colleagues across the county in general practice to make sure that access is effective. And I won't go into detail about that because that will be picked up at the next meeting.
Okay, thank you. We are running incredibly far behind. Our next speaker should have been on by now and only has till 12:30. So I am going to just move straight over to a proposal now. So I would like to propose that we note the information presented on the Community Pain Management Service, including the rating of good by the Care Quality Commission in June 2021, and actions taken in response to the high-level review of complaints in June 2021. I would also like to propose that we note the positive direction of travel of the service, but with 3 of the key performance indicators still not reaching their target, to receive a further update on the service in 6 months, and also there is mention of an action plan that this is shared also with the committee. Do I have a seconder to my proposal? Thank you, Councillor Mrs Wootton. All those in favour, please show. Thank you, that's supported. Thank you very much for attending today, Sarah Jane.
Thank you, Carl. Apologies, Caroline.
That's not a problem, thank you.
Thanks a lot, bye-bye.
Thank you. Okay, we'll move on to agenda.
Mr Chairman, just for the sake of everybody here, and Sarah Jane, if she's still on, the NHS website lists CKD as chronic kidney disease.
Okay, thank you for that clarification. In which case we'll now move on to agenda item 7, North West Anglia NHS Foundation Trust. We've got an update on pages 59 to 90 of the agenda pack, and I'd like to welcome our presenter, Caroline Walker, Chief Executive of North West Anglia NHS Foundation Trust. Apologies for keeping you waiting, so we'll hand over to you just to run through the pack. Thank you.
Hello everyone, thank you for inviting me, it's been a while. It's normal for me to come and update you at these committees, and it's always a delight to, but nothing's quite normal at the moment, is it, in healthcare and indeed out in our communities. But thank you for allowing me to come and talk to you today. I've got paper at item 7. Hopefully you've seen that, and I'm going to sort of just draw out some things for your attention, and then happy to take questions on any points of this. So we've been rather busy since we last met, since I last came to see you at the town hall, and dealing with the pandemic. As we sit here today, I've given you a little sit rep of where we are, but just by way of context, since it is pre-pandemic, since I came to talk to your committee, since we last met, since I last came to talk to your committee, the hospital has treated over 6,000 COVID patients within the space of the year and a half. Sadly, we have had over 600 deaths within that number. And as we sit here today, there are 60 patients within our hospitals, positive COVID patients, which is significantly less than it is has been on some days, but rather a little bit more than we might have forecast at this point in the pandemic, with the vaccination taking its impact. And the patients that are in our hospital as of today are probably about 10 years younger, the ones that were in the hospital in the first and the second waves of the pandemic. So that's something that is having an impact, and there's definitely a feature in that the patients in our hospital at the moment haven't had 2 doses of the vaccine or haven't had any doses of the vaccine. So changing response to what we're dealing in the post peak of the pandemic world, we've adjusted our services on site. I've given you an update on the things that we've done to segment our sites to make sure that we can adequately care for COVID positive patients and COVID free patients and keep everybody safe inside our hospitals. That's affected particularly the Stamford site that I'll come on to talk to you about within that. But we have quickly learned how to care for COVID patients and treat them, and thankfully the mortality rate has significantly reduced from the COVID positives that we do have now in our hospitals that you will have seen. So lots happening inside our hospitals. Unlike in the first wave and the height of the second wave, we are trying to treat urgent patients and COVID patients and planned patients at the moment. For the year that we've just had, you'll be aware that our waiting lists across the whole of the NHS and in North West Anglia have increased, and we're trying to bring back patients now as safe as we can to reduce those waiting times. It's going to take us some time, but we're working hard on that. One thing to point out to the committee that's something that I guess communities are struggling to figure out at the moment is that the rules outside the hospital are very different to the rules inside the hospital for infection control. And inside the hospital, we do still have strict infection control arrangements. We do still have our visiting restricted, and that's in line with national guidance from Public Health England. And as a result of the fact that our hospitals are full of vulnerable people who need to have those higher levels of infection and control than possibly might be outside our hospitals in the community, and with the things that we're allowed to do and the gatherings we're allowed to have. So that's where we are with COVID. We're committed to reducing our waiting list as quickly as we can. We are doing extra work to do that, and we're using the independent sector. And certainly Stamford's played a very big part in reducing our waiting list as they've taken more and more activity, more and more patients on that site. And we've managed to keep that site COVID-free virtually entirely throughout the pandemic. And they've played a big role in doing that for us. And we've called it a green site because there are no urgent patients turning up to that site who might be COVID positive within that. So that's where we're at. Staffing's a big issue for us at the moment. So whilst we're trying to cope with our hospitals being very busy for urgent care, very busy for planned care, we're also trying to cope with the fact that our workforce is affected by COVID in the community, and some of our workforce absence rates are higher than we would want them to be, as our staff as well as the community contact COVID or are contacts of COVID patients in the pandemic, as we've called it. That's taken its toll, and that has meant we've had to restrict some of our services over the last few weeks and month, which we hadn't really forecast at this point in the pandemic, as we wanted to recover during 21-22. My paper goes on to talk about specifics around Stamford and Rutland Hospital, which is where patients, particularly from the Lincolnshire localities, come to. Just to reassure you that we're continuing our development of the Stamford and Rutland Hospital site. We're refreshing our clinical strategy, and as I've just said, our clinical strategy was particularly affected on this site during the vast majority of last year, as we tried to do more and more planned care there, and more day case and outpatients there, with the specific aim of keeping that site COVID free and playing its part to help out the other two sites that were under pressure from COVID. We're still continuing to sell off a part of the Stamford Hospital site that's surplus to our requirements, and we're working with a buyer who's trying to buy the site and develop a nursing home on the site, as well as developing our clinical strategy to make the best use of that site and create a community hub on that site within that. One thing that we haven't talked about together as a committee is the fact that we did close the minor injuries unit at the early part of the first wave of the pandemic last year. And we did that quite specifically because we didn't want walk-in patients coming to the site who we didn't know would be COVID-free or be COVID patients. And we plan to reopen that again on the 1st of October. That's something that we've kept closed as long as we possibly could, to try and get that site having planned care and meeting our needs for reducing our waiting list and reducing our outpatient waiting times on the site. But we're gearing up for a 1st of October reopening of that on the site as quickly as we can do that within the safe environment. I've mentioned in my report some other things that will be causing issues for Lincolnshire patients and Lincolnshire population. Maternity services, lots of our patients and women do come from the Lincolnshire constituency, and we have been struggling within our maternity services some days on some weeks in the last few months, as we've been coping with wanting to increase our staffing levels and enhance our service, but also affected by the absence of staff and some pressures on the site. And in doing that, we've had to assess our clinical risk on various days, and that has resulted in the suspension of some of our services outside the hospital for home births and things. As we sit here today, the units are in a slightly better position, and our home birth services have been switched back on for certain scenarios that allows us to do that within the staffing levels we've got. But we do have significant staffing levels some days on both sides, the maternity services on the Hinchinbrook and the Peterborough site. The Peterborough site's where the vast majority of Lincolnshire women come to deliver their babies. So I'm happy to take questions on that if there are any. And I guess just to say that we've been busy, as well as coping with COVID and the pandemic, we've been taking forward some of our strategic projects to try and improve our urgent care performance. And in doing that, we've completely reconfigured our ED department on the Peterborough site and transferred over the urgent treatment centre that was down in the centre of town on Thorpe Road in Peterborough. And we've now co-located that in the heart of the A&E department at the City Hospital, with the aim of having one point of location for patients to come for their urgent care needs 24/7. and that's something that's moved successfully. We've expanded our department, but we still have some work to go on making sure the right patients come to that service rather than go to primary care or other urgent care services that they might need to go to. So they're the things that I've updated the committee on. Hopefully that gives you a quick run through of everything that has happened since we last met. I think it's fair to say that the last year has been something that we didn't forecast and has been unprecedented for the health service, and you'll know that. But hopefully I sit here today knowing that we're doing all we can to recover from what we've been through and to readjust to the new normal inside our hospitals and in the communities around us. Happy to take questions on any item within my paper or any questions that the committee have got. Thank you.
Thank you, Caroline. I'll open it up to questions. Councillor Cleaver first, please.
Thank you, Mr. Chairman, and thank you for the presentation. I'm often asked about the return of the mobile breast cancer screening service to Stamford Hospital, if you comment on that. I'd also like to ask whether, in the light of the sale of land, whether there is no longer any scope at all for expansion of primary care on the Stamford site, because obviously that was something which was being looked at. And I just want to know whether there is any future in that possibility. I think I heard you mention a community hub when you were talking about the use of the sold land. I didn't quite catch what you said, so if you could clarify that as well. Thank you.
Okay, so the mobile breast screening unit is something that has been asked several times. I've been asked that question in my board meeting by the members of the public several times. So the service isn't at the moment happening. It's been centralised back to the Peterborough City Hospital site during COVID, and as we currently stand, the mobile unit was based at Stamford and went around some bits of the south of the county. With the COVID environment and with some of the GP clinics reconfiguring, that van's not been allowed to go out to those other services because of COVID arrangements and because of the arrangements for staff. So we're asking patients to come to the Peterborough City Hospital site. So the van's located at the Peterborough City Hospital site. And I think it's fair to say that that's working well, actually, and that we're hitting 2-week waits for that service and patients are accessing that service well. So while it remains hitting targets and we're not specifically having any issues with delays to patient care, we plan to keep that on the Peterborough site. We will keep reviewing it, but at the moment it isn't something that we've planned to keep moving around the county while we're still facing a community infection rates and community COVID arrangements as they are. The other question was about the land sale. So I mentioned about a community hub, not necessarily in relation to the part of the land that we were disposing of, but the rest of the Stamford Hospital site does have secondary care services, and as we know, primary care services on site, but community services, mental health and voluntary services located on different parts of the hospital as well. So when I refer to a community hub, I refer to the fact that it's not just secondary care on that site, and it is a health campus or a health community hub, as we might want to call it, within that. And I've forgotten your final question.
The use of primary care.
Primary care. I mean, there's space on that site. The evaluations that we've done so far and the communications people will be well versed on over the lakeside practice, which you've talked about earlier on the agenda. The decision by Lakeside wasn't to expand further and to take use of the surplus land. So whilst there is space on the site, there's no plan at the moment for Lakeside, I don't believe, to expand on that site. They certainly haven't been talking to us about it for some time now. So the proposed sale of the spare land at the moment is going to a company who intend to develop a nursing home rather than a primary care facility. But there is still other space on that site that could be utilised for other healthcare services should that be required.
Thank you for that.
Thank you. Councillor Parkin.
Thank you, Chairman. Caroline, are you on track for that September date to fully restore the midwifery services? The maternity services. And have you had any, is there a sense that women are no longer, now that service was withdrawn, has it impacted on the number of women who were actively seeking home birth, and what are you trying to do to kind of promote that service and promote that offer if you are able to restore those services?
We hope to restore those services for sure. It's a vital part of our offer and a vital part of choice for women within that. We've got a very active Maternity Voices partnership and patient support forums that have been talking to us, and we've been assessing every day on its own. So it's not something that we're saying will definitely happen or not happen in September. Our forecast recruitment, the staff absences are expected to be better from now onwards. We actually have invested in 30 new midwives, and we're gradually taking on the new appointees and the new people starting in post, so it should only get better within those environments. What we do have to take into account, though, on every day, and every maternity unit does this, is the safety on the day. So if we have lots of women delivering in the unit and we have lots of staff absence, we do pull people in from our community midwifery service to cover the main site where the most clinical risk is, and then we ask the ladies who might want to have had a home birth site to the midwifery-led unit. So it's about balancing the clinical risk for the women, and whilst it might not be their choice, it is deemed to be the clinically most safe thing to do when we are short of midwives to support that. But we do actively want to have the home delivery service back up and running, and it's a national target as well as North West Anglia target to have more and more women being able to be supported to have a home delivery and in the maternity-led unit rather than a consultant-led birth.
Councillor Ray Woods.
Thank you very much, Mr. Chairman. Good afternoon, Caroline. I note that last year many of our residents from Lincolnshire were being taken to Peterborough Hospital by ambulance for treatment, and that there was excessive waiting times in Peterborough. Do you envisage that occasion will occur this winter, or have you plans in place to reduce those waiting times? Thank you.
Yes, I do have plans in place to reduce those waiting times. I'm not proud of how long sometimes the ambulances wait before the patient can come into the emergency department, but it's something that's happening across the country at the moment with the demands on the emergency departments. One thing that's quite quirky and not unique, but quite quirky about the Peterborough site is it's on the edge of the Lincolnshire, Leicestershire and Rutland, so EMAS ambulance service, and it's impacted by the East ambulance service for east of England as well. So both of those ambulances services bring patients to the Peterborough Hospital and don't necessarily always talk to each other to manage the amount of them that turn up at the same time. So we're working hard with the ambulance services, both East and EMAS, to make sure that they don't all send ambulances all at the same time, because that is one of the factors that causes us to have delays in offloading the ambulances into the department. If they all arrive at the same time, it means that it's impossible for us to assess patients and get them into the department as quickly as we might want. And also we've been having some extremely busy days. Over the course of the last 3 months, we've had some record-breaking days for attendances at the Peterborough and the Hinchinbrook sites. And with those increased numbers, we've been struggling to offload ambulances and get patients treated within a 4-hour target as well. But the simple answer is we do hope to improve the ambulance waiting times and reduce the length of time that patients are staying in the emergency department. Part of the transfer of the urgent treatment centre from the centre of town was part of doing that as well, and to try and make sure all of our minor patients were treated in the UTC, that freed up the rest of the department to cope with the patients who arrive within an ambulance. We've got improvement plans to try and reduce the waiting times, as we stand here at the moment, they haven't had a massive impact, but we are trying to do all we can to make sure that we do what we can. One of the big things that affects ambulance waiting time isn't the number of attendances on the day, or isn't whether they come from East or EMAS. It's whether we can discharge patients who are ready to go home, because unless we can discharge patients who are already in the hospital and might have been there for some days, we can't actually get patients out of the emergency department who we've decided to admit, and then we can't get the ambulances into those bays, the ambulance patients into those bays. So it's called flow, and unless we can flow patients through the hospital and discharge the most low-risk patients who have been deemed ready to go home, we can't get them in, and it's as simple as that. The ambulances keep arriving, and unless we can discharge early in the day or appropriately each day medically fit patients, we will always struggle to bring ambulances in at the volumes that we're seeing. So it's something we're working on. Discharging patients to home or discharging patients to social care or other care settings is something that as a system we're working on with Cambridge and Peterborough and Lincoln as well. But it could be better. And certainly we plan to do extra things and do more things in winter as we cope with forecast extra COVID and non-COVID patients. But it does remain something that we struggle with. And we really have to figure out whether we've got the right capacity over the next couple of months to cope with winter forecast increased levels. But it's something we're working on, and it's extremely difficult to resolve. But we're committed to making sure we do all we can to make sure that we reduce the risk and reduce those waiting times, because it's not good experience and it certainly compromises safety when it gets to long lengths of stay.
Thank you, Caroline. Thank you, Chairman.
Thank you. I don't have anyone else indicating to ask any questions, so I just have two of my own, and that is, aside from those outlined in the report, does the Trust have any major plans for development in the coming year?
Not necessarily relevant to Lincolnshire patients, but we're doing lots to develop the Hinchinbrook site. Hinchinbrook site is a much older hospital than the Peterborough site. Well, it's not as old as Stamford, but we've got redevelopment plans for the Hinchinbrook site and some big issues to deal with there, and we're trying to secure funding for that. We're also trying to do lots of things inside the hospital to improve some of those things that I talked to you about over the ambulance waiting times or increased flow. So we've created things inside the department, inside the hospital, called a frailty unit. So reconfiguring beds to create a frailty unit or other things. So whilst they're not as big as some of those other things, there's still things we're doing to try and improve our care inside the hospitals. We've also reconfigured some of our out of hospital services with GPs so that we're only bringing patients to the hospitals when we need to as well. So working in integrated neighbourhoods to make sure that some of our services move out of hospital, and some of those heart failure clinic and other things spring to mind as well. So some big things that we're doing that hopefully will reduce the pressure on the acute sites and ensure that patients can get the care closer to their home, or in primary care if needed, or in primary care clinics when they previously might have been asked to come to the hospital for them. So there's some of the big things that we're working on at the moment. The Stamford redevelopment is one of the big things as well, so we do need to keep you updated on that and make sure that you're familiar with all the things we're doing on that site. It's pretty key to the management of the 3 sites that we have. Thank you.
Thank you. And I think you've alluded to this in part, but what is the current level of staff vacancies across the Trust, and what is your recruitment plan to fill these vacancies?
Yes, I do often say if I had a magic wand for the NHS, my wish would be to have no vacant posts and everybody in post. That would be my magic wish. So our vacancy rate as we sit here today, I think is just over 5%. So we've got about 7,000 members of staff, so a few hundred. Our permanent vacancies run at about 3.5–4%. So the absence rate on top of that is people who aren't here because of COVID or because of isolation, or just general sickness as well. We particularly have been successful during COVID of keep going on our international recruitment, and our nurse recruitment is way below the average for the whole of East of England. So we're doing quite well. We've got some hard to recruit areas. We've already discussed maternity on this meeting, and having taken a decision to invest in 30 extra midwives for the year, I think we've recruited about 20 of them. So we've still got a bit further to go on midwives. And we have certainly invested in probably about 20 or 30 more staff in each of the ED departments to cope with the increased activity that we've seen. So we've still got pockets of vacancy within an overall vacancy and recruitment need rate. We've got some pockets of areas that, like ED and like maternity, that are affecting service delivery at the moment. But overall, our staff vacancies are quite good compared. We will keep going on that. But nurse vacancies are probably one of the lowest in the region, because we've continued with our international recruitment. So it's not something that goes away. It's not something that isn't something we have to keep on top of, and it does cause problems when we have particular pockets, like I've said, of high vacancy rates or high absence rates. But at the moment, it's better than it has been for some time, and something that we're actively working on all of the time. And as well as recruiting, because you mentioned recruitment rates, we're also doing lots of work to support staff and support staff's health and well-being, and that hopefully will help our retention rates as well, so that staff don't feel the need to leave, and supporting staff with their training, development and talent management as well. So lots happening on that agenda, but still, the net result is that we have vacancies in some areas, and we do ask, we do use bank and agency staff to cover those gaps to deliver safe services. But it remains a priority for us to keep recruiting and to retain the staff that we've got. Thank you.
And then very finally, would you be happy to share your 2-year recovery plan with the committee at all, please?
So that it's the recovery plan for the waiting list. We haven't finalised that yet. The whole of the NHS have been asked to put plans together as part of the thing called H2, the second half of the year. It's not a high-speed train. It's this half 2 of the financial year. We've been asked to put plans together to recover our waiting list before March 24. So almost a 2-year recovery plan within that. So once we have it, I'll be happy to share with you. Some of our specialties are already recovering and reducing their waiting lists. We're using independent sector and Saturday lists and things like that. But others where we've got big waiting times will take us a little bit longer. So it's a mixed picture, but happy to share once we've done that work.
That's brilliant. Thank you very much. In which case, I would like to thank Caroline for her attendance today and to propose that we note the information presented by North West Anglia NHS Foundation Trust, and to thank all the staff at the Trust for their efforts in response to the COVID-19 pandemic over the last year, and that we request a further update in 12 months. I have that seconded. Thank you, Councillor Mrs. Wootton. All those in favour, please show. Thank you. That's supported. In which case, we'll move on to our next item, agenda item 8, nuclear medicine. This can be found on pages 65 to 71 of the agenda pack. And I'd like to welcome our presenters from United Lincolnshire Hospitals Trust: Simon Evans, Chief Operating Officer; Laura White, Head of Nuclear Medicine; Anna Richards, Associate Director of Communication and Engagement. I can hand over to you for about 10 minutes just to draw the points out of the paper, please, and we'll take questions at the end. Thank you.
Thank you very much, Chair, and thank you for letting us come and present today. The report, hopefully, is a relatively self-explanatory report and echoes one that was taken to our Trust Board this month, which essentially starts the process of examining nuclear medicine. Nuclear medicine is a relatively small but very specialised service that we operate across our sites, that we have examined over recent months, and in particular looking at its ability to sustain services going forward. In the report, it describes a number of the issues that we have with the sustainability of this service, and actually present challenges that we have, both from a workforce but also from an equipment and the configuration service that we have. The configuration of nuclear medicine largely represents the configuration that was in place actually before the conception of United Lincolnshire Hospitals Trust, when there were multiple trusts, and it hasn't substantially changed since then. So what we're here for today really is to describe the challenges that we have within the report, essentially the mandate that we've been given by our Trust Board, and invite Overview Scrutiny Committee to progress with us the engagement process and start the discussion and preliminary options appraisal, which we'd like to do over the course of the next month with a wide group of stakeholders, with a mind to then proposing a consultation next month through to our board, and then, if acceptable, back to the Overview Scrutiny Committee to start the formal consultation process off. So essentially, what we're saying today is that we'd like to start that engagement process off, this is the reason, these issues within this paper is why we think we need to do something different, why we need to consider the different options of how we provide the service, with a mind to starting a proper consultation off next month. With me today, I've got Laura White, who's a consultant physicist. Nuclear medicine is a highly complex service. I wouldn't profess to know all of the things that happen within that service, and I'm sure be able to answer any very specific questions, but I'm sure more will come next time when we start to talk about options and the potential changes that we might make going forward. And then for that, Chair, that is really all I'd got in terms of update and presentation, and just happy to take any questions from colleagues.
Thank you, Simon. Do we have any questions, please? No? Yeah, Councillor Woodliff.
Thank you, Chairman. Well, I suppose the question is, what qualifications do you need to start this? Because obviously we're very short of staff in this area, so it's very much a specialised area. So if some young person wanted to take this on and go down this pathway, what qualifications would they need? Would they need a degree in physics, for instance, to do this? Is this the type of thing that we'd be looking for?
It is a, sorry.
Carry on.
It is a highly specialised service, and you do need huge amount of both experience and qualifications and scientific background, and that's part of the difficulties we've got in terms of being able to sustain a service across all of Lincolnshire, and our ability to be able to recruit people in at an early enough stage so that they can then go on through apprenticeship and training and through to fully competent specialists. But I'm sure Laura will be able to articulate what some of those specifics are around the qualifications.
There's two main type of staff that work in nuclear medicine. So we've got the technologists who tend to do the patient scans. Now they tend to come through a route where they will have a degree and then they specialise they actually do training on the job to become specialised. We've actually just recruited an apprentice who's come from A-levels, and we'll take him through a degree to then be able to be a trained clinical technologist. Myself, I'm a medical physics expert. To be a medical physics expert, you need to have at least a physics degree and an MSc and some training. Subsequent to the MSc, I've actually got a PhD in nuclear medicine as well. So that it would normally take about 10 years to become an MPE, which is why there's a shortage of them, because the training is quite protracted.
So if I can come into that, there's little chance of having these people, because it's almost impossible to get people to study physics at university. It's everybody wants to study all the other things. It's a hard degree, very hard.
It's increasing from when I did it. There's more physics degrees now than 20 years ago.
Well, there's I'd imagine there's a very small proportion of people who actually want to do it, though. I mean, you need a high degree of mathematics to be able to do physics. And whilst the numbers of people who are studying maths is increasing, we know that the quality of mathematics required to do physics is considerable. So I suspect there's going to be a really major problem. I mean, also, the other aspect is how much are these people paid? I mean, we hear about managers being paid a great deal of money. I wonder how much money people are paid to do this specialised area. It always comes down to the same thing, isn't it, really? How much money is allocated for the training and the payment of these particular people? The same thing applies in schools as well. It's another area. You know, physics teachers are not paid much. That's why there aren't so many.
I think the
same thing applies all the time.
Training is the clinical scientists. So I'm a clinical scientist. There's actually a national training scheme to train clinical scientists. So the physics is so if you've got a physics degree, you actually could become a clinical scientist fairly easily if that was your pathway. The issue we have is with the technologists, who are the bulk of our staff, because they've got rid of the national training. So we are now doing apprenticeships. The problem with the apprenticeship scheme is you have to actually sacrifice your wage. So we've had to get an apprentice to try and continue the workforce. We've actually we've used one of our technologist posts to fill it with a trainee for a thought of long-term planning. That's the only way we can train the technologists now.
I mean, I'm afraid to say it's all wishful thinking, really. This is the way it goes all the time. The real people are needed. Never paid the money to be able to do these things. People always assume that there'll be those people around which they can then pick off. The same things in the schools. It's the same problem at the same time. Specialist people, not as important as those in management. Management, £300,000 a year. I've no doubt some of these chaps here, if they're doing it, £30,000 a year. I suspect that's a problem. Chances of this being recovered, remote, I suspect. It's a real big problem. It is really down to valuing people for what they do and for the qualifications they have. And we don't do it in this country. We just don't do it.
To be fair, clinical scientists get paid reasonably well in the NHS
well, I'm sure.
because the actual qualifications that are required to be a clinical scientist are high, and the Agenda for Change pay scheme is based on qualifications required. The technologist, on the other hand, well, they get paid similar to a radiographer who works in CT.
So what's reasonable?
Radiographers are well, the technologists are a band 6, which off the top of my head I think is about £35,000.
Right.
So the system that we have in the NHS obviously rewards experience, specialist skills and education, and because actually this, as Laura's explained, the scientific roles have got a requirement for both a sort of specialised education and specialist skills as well. Actually, they are very reasonable salaries, and they're on par with our clinical teams in terms of professional nurses and doctors.
But you don't have these people, do you? So your reasonableness doesn't really apply. The argument falls down.
Councillor Woodliff, this isn't an open conversation.
Okay, I'll leave it at that, Chairman. I'm getting too annoyed with this, really.
Okay. Councillor White, please.
Yes, I'd just like to ask why the national training finished and why they just left it.
So would I. There was an interim period where if you had a physics degree, you could do a fast track for a year to become a clinical scientist, but to become a clinical technologist. But once that went, it was basically left to individual trusts. So we are trying to work with our colleagues in the Midlands to see if we can sort of try and train people, well, we're just looking at what we can really do, because could we give a bit of budget and Nottingham give a bit of budget and Leicester give a bit of budget to actually try and train these, because it's very difficult to give up a vacancy to train somebody. So the Charles who we've just taken on, it's going to take us 3 years to get a technologist out of him. So if somebody leaves, it's quite difficult to recruit. We had a recruitment technology, we tried to recruit from abroad, and it took 2 years, and for a number of reasons didn't happen. So we had 2 years where we were struggling to try and recruit somebody from abroad. To be fair, we used to get quite a lot of technologists from Portugal. They had a very good nuclear medicine technologist training scheme, and that's also gone.
Does that training have to be done in hospitals, or could you attract that training at local educational institutions?
I think what we've described is we are now starting that process. So in terms of the apprentices that we've got and how we bring that up, and we're having to do that within ULHT. And of course, for those that are studying qualifications at university, we'll do that, of course, in partnership with local universities and local education. Where we can, if we can start to do this super regionally, and as we've said with Nottinghamshire, perhaps with Derbyshire and Leicestershire, we can build a greater hub. In terms of the national decision, we weren't part of that decision, so it's difficult for us to be able to say why that happened. We're just now making sure that in terms of our planning going forward, we're having to compensate for that where we possibly can, and make sure that we've got people that are coming in the pipeline but as Laura said, that will take time given the lead time that it takes for people to become qualified.
We've
Thank
been
you.
training for 10, 15 years, and so the problem we've had is that quite often the trainees we've had from the national scheme have not been local, so they've not had roots in the county, so we tend to train them, which is obviously a lot of resources, and then they tend to go back to where they grew up, or they tend to go where their boyfriends or girlfriends live. We actually have just recruited somebody who was educated across the road from the hospital in Lincoln, so all his roots are in Lincolnshire. I thought he was the best person for the job rather than we recruited because he was from Lincolnshire, but it just so happens that actually he was educated in Christ school, and he is very good, so we're very optimistic that he will stay for a period of time. But it's not unique to Lincolnshire. This is a national problem in nuclear medicine.
Thank you.
Okay, thank you. I've just got a couple of questions as well. Does the Trust have an idea of the content of the engagement proposal? Is the plan for a 2-site model or a 1-site model?
I think at this stage we don't want to preclude any options. We've been learning, the best approach in this for any kind of service configurations is to keep the options on the table and to start that engagement with that in mind. The likelihood is that we can't operate the 3-site models that we have currently, and those reasons are put in the paper that we've described. But at the moment, we would want to work that up as part of the options and then put that in then to the consultation further on down the line.
Okay, thank you. But hypothetically, what is the impact of stopping the service on other services at any one of the hospitals? Would this mean they would have to stop also, as the relevant diagnostics would not be available?
We've articulated elements of that in this paper in terms of the links with radiopharmacy and some of the most critical elements to that. But we would want to develop that as part of building the options, so examining the knock-on consequences. In reality, the overall impact on other services, the greatest amount of impact will be on Lincoln, because of the concentration of cancer services at Lincoln itself. But ultimately, we want to go through that as part of the engagement and as part of developing these options.
Okay, thank you. So what are the expected timings for engagement and then in turn, doing a full-blown public consultation?
And I'll be looking to make sure that my colleague Anna makes sure I don't get any of the dates wrong. But ultimately, we're looking to engage now with post this meeting to start working with key stakeholders on the development of these options, with a mind for our next trust board, as in the October trust board, to present a consultation pack that we would want to share as part of a formal consultation. And then, subject to board consent for that, we would want to present that to Overview Scrutiny Committee next month, again for to start that process off for input from Overview Scrutiny Committee and as well as broader stakeholders. And then once closed consultation period, at that point, then we'll obviously settle on options and then take that back through that route through board and to confirm the preferred options.
Okay, thank you for clarifying that. I think at this stage, there's not much for us to really go on, so I think I would be more than happy to propose from the chair that we do support that you begin this engagement part of the exercise and that you do come back to the committee with a little bit more meat on the bones for our next meeting before we sort of take any further decisions and know the full content of what we're looking at. So that's my proposal from the chair. Thank you, Councillor Wootton. All those in favour, please show. Thank you. That's supported, and we look forward to hearing from you from the next month's meeting. Thank you for your attendance today.
Thank you very much. Thank you for your questions.
Thank you.
Bye-bye.
In which case, I'd now like to move on, please, to agenda item 9, bear with me, I'm losing my paper. The work programme. Simon.
Thank you, Chairman. If I could just ask the committee to look at the list of items on page 74. For the October meeting, we are expecting an item which will introduce the consultation on the Lincolnshire Acute Services Review. And another item, the second item on that list, is the one that has been mentioned earlier this morning and at previous meetings, which is to be led by Dr. Kieran Sharrock from the Lincolnshire Local Medical Committee on, if you like, the new GP practice, some of the developments and challenges there. We also just need to add nuclear medicine, which I was a bit surprised by, but anyway, onto the list for October. And the other meetings, I won't go through each of the items, but the other items for future meetings are also set out on page 75. Thank you, Chairman.
Thank you, Simon. Do I have any comments? Yes, Councillor Matthews, please.
I think it was Councillor Parkin beat me by
Councillor Parkin, would you like to go first? I didn't spot you first. I think it's line of sight.
You're very polite, Councillor Matthews. Just wondering, we had previously talked about NLAG giving some input into those services last end, you know, people going from Louth into Grimsby. It was good on the to say, you know, today's paper to see that being addressed for the south of the county. Just wondered if there was an update on that, Simon, as to when we might have that.
I understand that we are expecting an item on the Humber Acute Services Review engagement exercise, which is likely to impact on services. So I know there was a certain amount of information that was in the papers today. I need to get back to my contact there and just check on the timings for that. But that is something we have been told will take place this autumn, but that is a loosely defined term. But yes, thank you.
Thank you. Councillor Matthews.
Thank you very much indeed, Chair. I think Simon's referred to this, but it's about the proposed item 2, GP practice developments and challenges. And I wonder if we could ask you to focus that to also include concerns about the quality of GP practice, following on the comments about Lakeside earlier in this committee meeting, and the Ipsos Mori poll that was undertaken on behalf of the NHS that showed that the two worst practices in Lincolnshire happened to be the one in my ward and the one in your ward, and significant numbers of concern expressed through an Ipsos Mori, a high quality poll. And I just wonder if we can be sure that is addressed in item 2 by asking them to address it, if you like, so that we don't, that frustration doesn't continue. Because I think Councillor Cleaver did raise this serious issue earlier, that we need to have some, and indeed so did Councillor Moss, that we need to have some way of tracking the performance of these people and responding to them. And at the moment, I don't understand what that is, and I'd like to learn. Thank you very much, Carl.
Yep, thank you. I'm sure we can pick up upon that. That's something. I would just say, actually, the one in mine's now just been passed as good, so which is quite a surprise, realistically. But yes, certainly I'd take that on board. Councillor Cleaver.
Thank you, Mr. Chairman. Based on obviously what's been said today, I would like there to be a future session on lessons learnt from the CCG, but actually 2 sessions on lessons learnt. One about the quality of GP service, which we've covered off already today. I don't need to explain further about that one, but also lessons learnt about contract management of GP services by the CCG. There were a number of instances, again, unfortunately, with Lakeside, that touch on that all came about over the attempt to close a surgery without prior permission from the CCG, about a dysfunctional relationship with the PPG as well. So I think it's quite apposite that we hear from the CCG the lessons learnt in terms of the management of their contracts and their relationships with GPs, as well as, and separately from, the quality of care that those GPs provide. Thank you.
Happy to take that on board. The one thing I would say is our workload is about to get incredibly full with 2 acute services review taking place in very similar times. So I think what might be better perhaps is if we speak to our colleagues in the clinical commissioning group and perhaps look at doing a separate session to go over lessons learned that is perhaps less formal, and so we can actually concentrate on it and the contractual things where they may more be likely to open up on what the position is. But I'll speak to Simon and we'll see what we can come up with. Any further comments? No? Okay. We've taken all that on board. Are we happy with the work programme moving forwards? I'm happy to propose it from the chair. Thank you, Councillor Watson. All those in favour, please show. Thank you. That's the work programme move forward. I'd like to thank you all for your attendance today and wish you a safe journey home.